Hello, everyone, and welcome. Today, I'm going to be presenting Pathophysiology and Epidemiology of COVID-19, what we know so far. Obviously, there's a lot we don't know about this virus, but the majority of this information was prepared by Alexia Cronice, our PT manager out of the Newark office, and also myself. So it is updated as of today's date, which is May 13th, 2020. So let's take you through some background information and what we know thus far about the virus. So what is COVID-19? Well, a coronavirus is a common virus that causes an infection in your nose, your sinuses, or your upper throat. Most coronaviruses aren't really that dangerous, so think of the common cold. Coronaviruses are single-strand RNA viruses that contain spike glycoprotein. So I have a picture of that for you, giving it a characteristic appearance. Most people will contract a coronavirus at least once in their lifetime, usually as a child. Examples of some more severe coronaviruses include the Middle East Respiratory Syndrome, which is MERS, or SARS, which was the Severe Acute Respiratory Syndrome. COVID-19 is actually a disease caused by the virus that is named SARS-CoV-2, and that stands for Severe Acute Respiratory Syndrome Coronavirus 2. Okay, so COVID-19 is the disease caused by SARS-CoV-2. So like I mentioned, the coronaviruses are named as such because of those spike glycoproteins that you see there on the picture. And because they look like a crown almost, so there's that coronavirus piece. And that's on the outer surface of the virus. So what actually is happening in a patient's body or an individual's body that contracts the coronavirus? So let's go through that process a little bit. I think it's nice to get back into that pathophys piece and get an idea of what's actually happening and causing and wreaking havoc in these bodies because of this virus. So what happens is the virus has to infect living cells in order to reproduce. So the inside of the virus itself, so we looked at that picture before and you see it here again, it has that outside with the spike glycoproteins. Well, inside of the virus, it actually contains genetic material that allows it to replicate or make copies of itself. So the outer envelope of the virus allows it to merge with the outer membranes of our cells. Let me kind of look at that a little bit more. And what happens is those protein molecules that spike out of it, that form that sort of crown-like or corona, they actually project out of that outer membrane or outer envelope. So the viruses use those protein spikes almost like a key to get inside the cells of the throat, the lungs, the nose, the cells in our body. So there's the protein spike, and there's the receptor that is on the surface of our own living cells in our body, and they sort of match like a key. So one spike inserts into a receptor on the surface of the cell, and what happens is that as it clicks in, it allows that virus to actually get inside the cell, and that's that picture you see here where the virus is actually going into the cell itself. Once it's inside, the virus can access ribosomes, which start the process of the virus replicating itself. And eventually what happens is that it replicates itself so much, it then is actually then released back out from the cell membrane. So how does pneumonia develop because of this? Well, our immune system is becoming very overwhelmed with the virus itself. Okay, so you see that. And what happens is because our immune system is working overtime, we have an inflammatory process that occurs. And particularly, it happens in the bronchioles, so those terminal airways, and the alveoli, those little tiny air sacs at the bottom of our bronchioles. And what happened as a result of that inflammatory process is that those alveoli start to begin to fill with fluid. And then what's happening is it's making it difficult for oxygen to diffuse from inside the actual alveolus to the capillaries that line it. So you see those capillaries that are lining each alveolus. And what happens is because there's fluid in the way, we can't have diffusion of oxygen across that membrane. And as a result, this is going to lead to the development of pneumonia. So in some folks, it may be lobar pneumonia, so it's occurring in just one lobe, or it could be what we call bronchopneumonia, where it's in multiple lobes. So you see some pictures of that there on the screen for you. So what are the symptoms of COVID-19? Well, first of all, let's talk about when do they actually occur. They can occur or show up in as few as 2 days or as long as 14 days after exposure to the virus. So there's where that 14-day period of quarantine comes in after exposure. And these 4 that you see here are the typical hallmark symptoms: coughing, high fevers, difficulty breathing, shortness of breath. That's where, sort of the hallmark signs and symptoms of COVID-19. But there are a lot of other possible symptoms, and some of these were updated in the last few weeks from the CDC. If somebody has fever, they may also have chills associated with that. Patients can have muscle pain and fatigue. They may experience headaches, sore throats. An interesting one that I have actually read some folks their own personal experience with COVID, but they lost their sense of smell and taste. And believe it or not, some people may have some GI symptoms: nausea, vomiting, diarrhea. I know there's a lot of talk going around in the last week about how COVID is potentially affecting children. And in a lot of those cases, it's not showing up with those 4 hallmark signs we just saw on the last slide, but they're actually first presenting with some GI issues and then end up going into a complex inflammatory syndrome that actually affects their heart. They can have issues then with breathing, and also some rash development. So other things to keep track of in our pediatric population. So stay tuned for more information about that as they determine it. So how is COVID-19 spread? Well, primarily it's spread through droplets. Okay, so droplets are those larger particles that happen when you cough, you sneeze. Those are droplets and that have the virus in them. It is less commonly transmitted through aerosols. So those are much more small particulate molecules that could potentially stay sustained in the air. Less common as well would be the fecal oral route, asymptomatic shedding, and then also contamination of surfaces. So the virus isn't living too long on surfaces, non-porous up to 72 hours or porous up to 24 hours. So those are some other ways that it could be spread. How contagious is it? The way that they look at, from an epidemiological perspective, the way they look at how an infection spreads or a virus spreads is measured by what we call the R naught. Okay, and this represents the average number of people that one infected individual will infect. Okay, preliminary COVID-19 data is estimating the R naught to be 2 to 2.5 for now, and this may change as the pandemic evolves. The R naught is not a fixed number. Like I said, it can change. It depends on human behavior. So how well social distancing is working. It can also be affected by herd immunity. I'm sure people have heard that. Some countries, I think it was Sweden, took the herd immunity approach to things, and basically that's saying that you need to expose everyone at some point. Some people will develop the virus, some people will not. They'll develop immunity to it. And also it can be affected, the R naught can be affected by a vaccine. So obviously that R naught can go down if we have more and more patients that are, individuals that are vaccinated. But once again, the vaccine hasn't been developed yet for COVID-19. So here, just to give you kind of an idea of the R naught, here's some examples of what the R naught is for different communicable diseases. So here you have the Zika virus. I know we were talking about that a few years ago. The R naught for Zika virus is anywhere between 3 and 6.6 people. I don't know how you measure somebody in 0.6, but there you go. Measles, and this is one of the reasons why it's so important to have been vaccinated against measles. Measles R naught was, one person could affect up to 11 or 18 folks. Ebola is only 2. HIV, that's something 3.6 to 3.7. The seasonal flu, 1.3. So that's the R naught for seasonal flu, and then the norovirus. So for every one person that gets it, they can infect up to 1.6 or up to 3.7 people. So there's just a little more information about examples for R naught. So what are the total cases? Well, I did look this up, and as of yesterday, our total cases in the United States were 1.3 million. In between May 11th and May 12th, there were 18,106 new cases. And unfortunately, our total deaths in the United States as of yesterday was over 80,000. So who are our vulnerable populations? So who are the people that we need to be most concerned for being very ill from the coronavirus. Those that are 70 years or older, unfortunately, their risk for major complications from the virus will increase with each decade of life. And those patients that are immunocompromised or immunodeficient, including those folks that are undergoing cancer treatments, because unfortunately, most cancer treatments are decreasing, your immunity, a lot of the chemotherapy, radiation, those types of things. So they are a vulnerable population. And also we have to consider our patients that potentially have any underlying chronic conditions. So maybe it's folks that have any chronic lung disease, so COPD or asthma or any issues with breathing, folks that have kidney disease or maybe are on dialysis, or folks with heart disease or cardiac conditions are certainly a vulnerable population. And then also our patients that have metabolic diseases, especially diabetes. Interestingly enough, as they're looking more and more at the data, there are some other trends that they're finding for folks that are more vulnerable or potentially can have more risk factors associated with COVID, and that would be folks that smoke, the population that are obese, or interestingly enough, a Western diet, so high in saturated fat, sugars, and other refined carbohydrates. So until there is a vaccine, that herd immunity, effective treatments, and social distancing is our best defense at this point. So COVID testing, what kinds of testing can they do? They can actually do a test for the virus itself to see if you have a current infection, but they also are doing antibody testing, which says that you have been exposed and your body has then developed antibodies to the virus itself. And just so you're aware, it can take up to, from 1 to 3 weeks after you actually are exposed to have your body actually make antibodies against COVID. So it is not yet known. So I know they're starting to have more folks do the antibody testing, and it really isn't known yet if you do test positive for the antibodies, if that's going to protect you from potentially getting the disease again, or how long that protection will last. So if you have the antibodies, does that mean you're totally safe for the rest of your life? We just don't know that information yet. I did want to take a few minutes to go over COVID-19 and the use of ventilators. For those of you that listen to our therapy treatments for COVID-19 patients, this is some information that we did talk about, but I think it's super important because it can really shed some light on a lot of the issues that our patients have. And at the start of the pandemic, putting folks on the ventilator was widely used because you had patients showing up super ill with their oxygen saturation readings in the 70s and lower. And 2/3 of all patients who needed critical hospital care were requiring ventilation, mechanical ventilation. Interestingly enough, some of those same patients weren't showing the same types of symptoms you would expect for somebody to have such a low oxygen saturation. Some of them could talk okay, they didn't feel short of breath, they weren't showing signs of any other organ dysfunction, so that is a small population, but there were some folks that weren't. However, our patients with hypoxia, so this is your low oxygen levels, they're also presenting with low CO2 levels. So it suggested that the lungs may actually still be exchanging air properly, but not necessarily as efficiently or effectively. So interestingly enough, that presentation of those patients where they were hypoxic, but they also had low CO2 levels, so meaning that they were still breathing off that CO2, like the CO2 wasn't rising. But that's interesting because that presentation is similar to what happens with folks that have altitude sickness, as opposed to like a typical pneumonia. So they have tried to change the approaches a little bit. They're trying to decrease the number of intubations, but it certainly is still necessary. And I'm sure you're seeing that in the media and the other people's personal accounts of having the disease. So what are the risks if patients have been on mechanical ventilation? Well, obviously death. Death is unfortunately a risk. 80% of patients that were COVID positive in New York City who were put on a ventilator in those early days were unfortunately passed away. As compared to other people that are put on a ventilator, only, if you are put on a ventilator for any other reason, only about 40 to 50% of those folks have passed away. So Rochester Regional itself has been using intubation as a last resort, and they're seeing percentages similar to the UK. So 80% of the people in New York City, you see 86% of people in China, but the UK numbers were only at 66%. So this is data that's from 2 weeks ago. Also, another risk is you could have what they call ventilator-associated pneumonia. So they call it VAP in the inpatient settings. And that is actually a secondary pneumonia that is from different pathogens that colonize the tubing, right? Because you have the patient is intubated and you run the risk of anything getting into the actual circuitry of the vent itself. So that's a VAP or a ventilator-assisted pneumonia. And then other unfortunate risks or complications would be mental health and cognitive risks. You can have folks that have PTSD. Think about, feeling crappy, going to the hospital and waking up on a ventilator. Unfortunately, you can have folks with sort of Alzheimer's-like cognitive deficits, depression, especially in these times. They can't have family members there. They have no idea what's going on. They have, are surrounded by people that look like they should be, on a foreign planet or something like that. So a lot of mental health and cognition issues that can result. And then also, as we well know, is the potential complications of prolonged bed rest. Some of these folks are on the ventilator for weeks. And, that's the average, as you see there, is 21 days, right? That's like 3 weeks. Think of just laying there for 3 weeks, all the things that can happen, right? Not only from a respiratory perspective, we talked about the psychological piece, but think about, any issues with potential skin breakdown. You think of people being immobilized, they could have issues with DVTs or any clot formation. When you go to start sitting them up, they could be really postural hypotensive. And just think of what's happening to their bones and their muscles, right? They're losing strength. Typically, what they say with bed rest is you lose anywhere from 1% to 3% of your muscle mass per day. So think of how weak these folks are. Do they have any issues with contractures related to positioning? Their overall endurance and activity tolerance is going to be in the tubes. And you may also have folks with bladder and bowel issues, right? Because they probably had a Foley catheter in. So maybe they have transient incontinence, UTIs, problems with constipation, depending on the kinds of medications they were on. So certainly a lot of things where us as healthcare professionals can really step in and help to make a difference as they recover with some of those unfortunate complications of prolonged bed rest. And then also, we have the risk of respiratory damage with mechanical ventilation. Let's talk about that a little bit. So like we mentioned with COVID, you have an overreaction of your immune system. So you have your alveoli that are filling with fluid, right? So we're having issues with oxygen exchange. So we don't have that ability to exchange as much oxygen even with the ventilator, right? We still have to have that surface area between the alveolus and the capillaries to actually have diffusion of oxygen. So what happens is they have to adjust those vent settings in order to attempt to oxygenate these people. And by doing that, what they're doing is they're increasing the force and the amount of oxygen that's actually put into the airways. And this, as a result, can cause more respiratory damage. So it can actually damage the lungs, damage the airways. Believe it or not, high levels of oxygen is actually not good for your system. It can shut down your respiratory drive because your body's like, well, wait, I'm getting all kinds of oxygen. Well, maybe not. So there can be a lot of issues that result in that, and that can cause further lung damage. And that's where, we're seeing people as they recover, that piece is coming along possibly a little bit slower for them. So what are some possible alternatives to mechanical ventilation they're working on? I know with folks that they're actually doing a lot of prone positioning, alternating with side lying. So they're trying to get people in prone. When you put people in prone, you're helping to increase blood flow to the front part of your lungs, help with ventilation in those lower lobes, which tend to populate more on the posterior part of your chest. They may try some non-invasive ventilation, so continuous positive airway pressure via CPAP, which is similar to like what people wear for sleep apnea, or BiPAP, which is it's by positive airway pressure, so it's pressure not only when you breathe in, but also when you breathe out. Also using inhalers to open up those airways. They may try, obviously, to go the route of delivering oxygen via nasal cannula up to high flow levels if possible. Another thing we're seeing a lot of information about is plasma donations from recovered patients, which is exciting. And some countries are actually using hyperbaric chambers to see how that affects folks, if they can use that instead of actually putting them on a mechanical ventilator. Let's talk about plasma donations a little bit. Obviously, if we have a patient that or a person that has COVID-19 that is receiving a plasma donation, the donor and the patient need to have compatible blood types. And they obviously test that plasma for different diseases, including COVID-19, HIV, hepatitis, to make sure they're not necessarily transferring any other communicable diseases. But there are over 100 researchers, 40 large hospitals in 20 states that are currently involved in these clinical trials. I don't know if you've seen some things in media, but I know, I think Tom Hanks just recently donated his plasma. He and his wife, unfortunately, were sick with COVID in Australia in the beginning of all this. So you have to qualify to donate your plasma, but here's some information that you see there on the screen for some of the qualifications. However, I know a lot of folks that have recovered are finding that they're really happy to do that, so whatever they can do to help people to recover, especially those that are so sick. So what are the drug treatment options that are being tested? I know we heard a lot about hydrochloroquine in the beginning. The trials didn't show anything with that, and they were, combining it with azithromycin. Now what they're really focusing on is that Remdezvir, and then obviously working on developing a vaccine. So Remdezvir, in early studies, they've been able to show, and here you have the original article, compassionate use of Remdezvir for patients with severe COVID-19. And in this study, they had 53 evaluable patients. 30 were on ventilators, 17 ended up being extubated. 4 of the patients were on ECMO. ECMO is extracorporeal membrane oxygenation. That is basically you were attached to a heart and lung machine outside of like an operating room setting. And what they found is when they gave these patients, the Remdezvir, 68% of them had an improved respiratory status, which is really great. It was not randomized, but what other good news is that Rochester General has been given permission to enroll patients in a trial for Remdezvir, which is awesome. And what happens from a coronavirus perspective, they tend to mutate less than influenza. And the hope is that because I know that this virus itself has mutated since it was originally identified, but the hope is that it will eventually stay stable over time. And if you look at this is a little graphic. This green piece that you see here is what the respiratory epithelial cells, that's the piece that attaches to those respiratory cells like we talked about and spreads the disease. And this is the piece that they're really focusing on from a vaccine perspective. So this was similar to how they developed the vaccines for both SARS and MERS. So that's how they were able to create those. This information is from a grand rounds that was given last month through Rochester General. So that's where they're working from a vaccine development perspective. And they do have a vaccine study going on right now at Rochester General. And I'm going to just skip over this slide because this is one that actually we're one of 4 sites nationwide to participate in this new vaccine trial. It is a randomized placebo-controlled trial, and they're actually looking for 90 different volunteers in the Rochester area, ages 18 to 85. Not been infected with COVID-19. Pfizer and BioNTech are actually working to develop the experimental vaccine. And this is a quote from Dr. Walsh, who is one of the infectious control physicians that's working on the vaccine trial. Obviously, we're moving from a scientific and medical community perspective at an unprecedented speed to try and get this vaccine developed, especially because of how easily transmitted COVID-19 is and how many folks it's affecting. Unfortunately, I showed you the numbers of how many people that have been infected and unfortunately have passed away. However, we can't forget science. Doing these vaccine trials have to be done in a rigorous manner where safety and efficacy of the vaccine itself is the most important. So this is really exciting. This is the first step. And if for any reason you are interested in participating, there is an email address there that you can reach out to, RGH COVID vaccine trial at rochesterregional.org. So if it's something where you think you might be interested, certainly reach out and help the cause, right? All right, so let's just finish up with reminding ourselves, what can we do to help prevent the spread of this disease? Well, we want to make sure that we're teaching ourselves and our patients to cover their cough and sneezes, washing our hands often. I don't know about you guys, but my hands are especially dry, not only from the continued cold weather, but also from washing them constantly. Avoiding close contact, so maintaining your 6 feet of social distancing. If you can't be 6 feet away from folks, make sure that you're covering. Got my handy dandy mask here, but covering your mouth and nose when around others, whether you wear a medical mask, a cloth covering, a cloth mask, when you're around others and cannot maintain your 6 feet of social distancing, to wear it. And then also making sure that you're cleaning and disinfecting surfaces. So many thanks to everyone for your attention. Just wanted to give you some background pathophysiology and epidemiology of COVID-19. So we hope this was helpful information to you. And thank you for your time. Take care and stay safe, everybody.